Dorothy. Welcome to Egg Donation Friends webinar number 12. Can you hear me? I hope you can hear me well. Today's topic is donor eggs, a precious gift. It's all about quality, number of eggs, and qualification process. Today's presenter is Dr. Robert Najdecki, Scientific Director of Assisting Nature IVF Clinic AWARD. His presentation will last about 25-30 minutes, and then the Q&A session will follow. You can type, if you want to ask a question, you can type the questions in the chat section. The webinar is being recorded, and you'll be able to view the recording on our website. We will also publish transcript with all the questions and answers. Dr. Robert, good evening.
Hello, thank you, Dorothy. Dear all egg donation friends, it's a great pleasure and honor to be here with you. Many thanks to organizers, IVF Media and eggdonationfriends.com for their invitation to such popular and high-quality webinars.
It's a pleasure to have you. Okay, we can start with the presentation, yes?
Okay, thanks. It took several years for egg donation to become a widely accepted method, but now it's a rather common solution for interfaith couples to conceive a child. Success rates with egg donation are high, particularly compared to pregnancy rates in women with poor egg quality and quantity. Research has also proven that the method has no adverse effect to the relationship between mother, father, and child, despite the lack of genetic link between mother and child. We are pleased to provide the procedure of egg donation, which is permitted in our country and is lawful under Greek law. Egg donation is anonymous, voluntary, and free. The primary benefit to every woman who donates eggs should be the altruistic aspect of helping another person or a couple achieve pregnancy. Every time a couple starts the egg donation program, a huge question arises. Who is the person behind the mask of anonymity that will offer you their eggs and a chance to parenthood? Donor eggs IVF opened up a world of possibilities for women who have struggled to conceive, women with primary ovarian failure, menopausal, either naturally or as a result of surgery, radiation of chemotherapy, women that have undergone repeated failed IVF attempts, or with a genetic disorder which could be passed on to their child. Egg donation treatment involves fertilizing the donor eggs with sperm from the recipient's partner or donor and transferring the resulting embryos into the recipient's womb. Basically, in Assisting Nature, we use two terms to describe those categories of patients: donor patient and recipient patients. Both of them are very, very important patients to us. However, we know and experience that in vitro fertilization treatment while using donor eggs is a more complex and difficult process. While two women are treated simultaneously, it is the donor patient that is young, healthy, and innocent that takes a risk of all possible complications. Nobody wants to talk about it, but the donor is our sensitive and very important patient. And this is the reason we must care about them, because they trust us. Finding a right donor patient is a difficult goal for every assisted reproduction unit. All eggs and sperm donors are anonymous by law in Greece. As a result, large numbers of donors are available, eliminating long waiting lists for treatment. So most likely your egg donation treatment can start straight away once a suitable donor is found. Due to the anonymity law, only non-identifying information can be given to a recipient. However, you will have access to the physical characteristics of the donor as well as the age, country of origin, and level of education. Our rigorous screening testing process ensures the highest quality donor eggs available anywhere. Our experienced team includes a medical director, genetists, midwives, donor egg coordinators. Each egg donor's individual and family health histories, medical tests, and other background information are rigorously studied to ensure she meets our highly selective standards. Donors are extensively tested and screened currently, including the following procedure. As you see in the slide, we select donors with proven fertile, age under 30, and the normal mental status. The screening involves psychological evaluation, motivation for becoming a donor, of course, medical history, fertility evaluation by hormone testing, infectious disease test, toxicology, and genetic screening. Our physician will review very detailed application, and if we are able to accept it, we will invite them to an orientation meeting. During this informational session, we will review all of the steps and details involved with being an egg donor and answer any questions they may have. They are more than welcome to bring their partner or a friend to this meeting, which lasts about 35 minutes to 1 hour. Furthermore, all of our donors are younger than 30 years old and of proven fertility, which means that they already have had a pregnancy of their own, either already have a child. So you can be assured that having your donor egg IVF treatment and Assisting Nature IVF is as safe as it can possibly be. Detailed screening of candidates donors is necessary to reject or to choose the right woman who can help other women to fulfill their dreams of motherhood, always in a safe and controlled manner. The first step of choosing the right donor is to examine them for particular risk factors and to exclude them from the donor pool. The screening includes psychological evaluation of a potential donor as well. The evaluation is important to guarantee the psychological status of the donor and to evaluate if this woman is truly ready to cope with the demands and the stress of her decision to serve as a donor. Applicants undergo a psychological evaluation with a mental health professional and take a MMPI test or equivalent to assess their mental health and emotional readiness to become an egg donor. This test is very difficult for the patients and difficult for the professional. It's about 300 multiple choice questions and answers, and it maybe lasts about 1 until 2 hours. We make sure each applicant has a through understanding of what is involved in donating her eggs in terms of time, physical implications, logistics, and last but not least, the medical risks involved in the procedure. Medical exams after the egg donor orientation meetings, we will help them book an appointment to come in to meet our physician for a physical exam, which will include a pelvic ultrasound and a blood draw for all the imperative screening. There is no cost for the appointment or any screenings, and no insurance information is required. The screening of donors include fertility evaluation by hormone testing, antimullerian hormone, follicle stimulation hormone, prolactin, estradiol, LH, progesterone, thyroid hormones, and other like vitamin D deficiency, vitamin B12 deficiency, and of course, vaginal ultrasound of the ovaries, endometrium lining, cytology, and full vaginal culture. In addition, besides the mandatory test for infection diseases, toxicology examination of the potential donors is required in order to exclude possible drug addicts from the donation program. We have added a also known as a urine toxicology screen to detect and evaluate the presence of illegal drug intoxication, ensuring that the individual selected to become an egg donor is drug-free. In this slide, we have again some information about screening of donors by infectious diseases testing. Here is HIV, hepatitis B, hepatitis C, syphilis, and genetic testings, full chromosome analysis karyotype, cystic fibrosis, natural killer cells, and fragile eggs. In order to be able to select a donor that doesn't carry the same mutation as the member of the couple who will provide the gametes, eggs or sperm. In addition to the test provided by the Greek law for male and female donors at Assisting Nature, we can also test for the more severe hereditary genetic diseases, specifically autosomal recessive disorders like Duchenne-Becker muscular dystrophy, cystic fibrosis, Gaucher disease, Wilson disease, Smith-Lemmy-Opitz syndrome, deficiency of acyl-CoA dehydrogenase, congenital disorder of glycosylation type 1A, or X-linked diseases like Fragile X syndrome, muscular dystrophy of the spine. Once they have completed their screening and application, they along with a photo will go to a confidential database accessible only by their egg donor coordinator, midwife, and treating physician seeking an egg donor to match potential recipient parents. Any identifiable information such as their name, picture, will never be available to our patients because it has been institutionalized by the Greek legal framework that egg of sperm donation is absolutely and strictly anonymous. Patients choose their egg donors for many reasons, often because they have similar phenotypic characteristics and interests. The information they have given during their application process will facilitate our patients to know if they have made the right choice for their future family. According to the donor-patient preparation, we must explain some important issues. In the past, we have been using long protocols to stimulate follicle growth. These protocols were very convenient for the doctors and units, carrying a high number of follicles and eggs, but extremely inconvenient for the donor patients, putting them into a risk of hyperstimulation, hospitalization, and serious complications. All these protocols were abandoned globally by good practices, especially when European Society of Human Reproduction and American Society of Reproductive Medicine have started their no hyperstimulation clinic campaign. It is extremely important to ask your clinic how they stimulate their donors. Will you feel well when knowing that your donated eggs were hyperstimulated only to achieve a higher egg number without any care of quality and donor-patient condition? What is the conclusion? Look for the clinic with high ethical standards, which use mild stimulation protocols and like car catalysts, protect their customers from extreme pollution. The second important issue is the number of eggs carrying into the program. Some clinics guarantee 4, 5, 6, 8 eggs, some other all eggs. What does it mean? Does the higher egg number influence in higher pregnancy rate? Let's try to answer it. However, before answering, we must realize how the program works. All oocytes designated for one donation cycles are involved into the ICSI procedure, and 24 hours later, we have eggs fertilized. This is the first step and first possible stage of losing some of the eggs. Afterwards, the incubation process from fertilized eggs until blastocyst stage lasts another 5 days, and this is the second possible period of losing some of the embryos. In this moment, we use the term blastulation rate. What do we mean by blastulation rate? It is the percentage of the fertilized oocytes which become 5th-day embryos, blastocysts. If we have blastulation rate about 50% or higher in our lab, which is a very good score and absolutely realistic, it means that from 6 oocytes used, at least 3 will reach the blastocyst stage. Here you have the tables and view like in the space program, what we see inside in the unit inside the lab. Here we have a case of the one donor patient and 2 cases with another fertilization process. In the left up table, we see that the first time we pick up 9 oocytes, and in the process of fertilization of ICSI, we lost 4 of them. Then we have 56% of fertilization. In the process of incubation into the day 5th, we achieved 3 blastocysts. We performed the single blastocyst transfer without any results, with negative results. Of course, we have another 2 blastocysts for future transfer. In the case down, from the same donor, we see that in the next attempt, we pick up 10 oocytes, and by fertilization process, we had 100% of fertilization, that we had 10 eggs fertilized. From this 10 eggs fertilized, we have 10 excellent blastocysts, and with the first embryo transfer, the patients was positive pregnancy test, and of course ongoing pregnancy go well. And what we see here, the same donor patient, but very different semen samples. And this is the problem. What's happened? Let's go. The way from an oocyte to a blastocyst is not always easy and predetermined. Not all oocytes become blastocysts. Finally, what matters? Eggs or blastocyst? And what about the male factor? As you see here, in the case of normal semen sample, plus 6, 8 eggs used, we have on average 3-4 blastocysts. But in the case of an abnormal semen sample, plus 8-10 eggs used, we have on average 2-3 blastocysts. What is the conclusion? There is a real value in every IVF program, and this is a blastocyst. Eggs and sperm are raw materials. Is there any way to check the quality of the blastocysts? Of course, yes. We check them by morphological assessment and by new methods, karyotype, by NGS, next generation sequencing. The euploid blastocysts have more than 60% possibility of implantation. And here we must say that exclusive and future ideal donation programs may include prenatal genetic screenings of all blastocysts by next generation sequencing. Another step in the preparation of the recipient is the embryo transfer test before the attempt, which we know like mock transfer, the ultrasound scans and hormonal tests during the substitution protocols, and hysteroscopy, which we knew like our study for all reproductive patients, and also pharmaceutical preparation of endometrium. Egg recipient is submitted also to the following tests: blood test versus complete blood count, antibodies for hepatitis B, C, HIV, hemoglobin electrophoresis, mycoplasma, ureaplasma, and chlamydia. Of course, also preparation of a spouse or sperm donor, same exams, plus, in many cases, DFA, DNA fragmentation index, that it's very, very important to us because it asks about the quality of the sperm. And the successful egg donation program must include the good coordination between the donor and the recipient, good donor preparation, high laboratory specifications, well-trained medical staff, proper preparation of endometrium. As you see in the chart here, the egg donation has proved to be very successful, either using fresh or frozen eggs, with success rates up to 59% for embryo transfer per treatment cycle and up to 71% for clinical pregnancies. One moment.
Oh, I'm sorry, Dr. Robert. I think
No problem.
might have
we are here. Okay.
Okay. I'm sorry for that.
Every year, we offer to our present and past donor patients free of charge tests and exams, such as mammography, breast ultrasound scanning, cytology, and blood testing. This year, we had 2 cases where we performed the hysteroscopic polyp extraction and breast adenoma extraction, always free of charge. We started to offer them detailed cardiological exams, sometimes even with triplex ultrasound scan. This relationship leads us to have always excellent donors and waiting lists never more than 2 months. We are not a unit with a mass egg production. Our concept is to offer you our donor with her eggs and not eggs of somebody. Assisting Nature's donation office is a completely separate service, which managed only by certified and the mostly highly expertized scientists. Our donation office is administered by the senior embryologist lab director, the senior midwife coordinator, and 2 supervising gynecologists specialized in assisting reproduction. Experience is a combination of knowledge and wisdom. Provider of assisted reproduction should be fellowship trained and board certified, both of which are the standards of our clinic. And finishing, let's take a look into the basic Greek law topics. The egg donation is an altruistic act, voluntary and unpaid. Donors are compensated for their days off from work and their physical strain with the framework of the donation procedure and for their travel expenses. Egg and sperm donation is permitted in Greece, provided the donors remain anonymous. Donation program for recipient patients is not permitted to women over 50 years old. Egg donors sign a consent form of acceptance in regards to donating their eggs. Recipient couples sign a consent form that they agree to undergo IVF treatment with oocyte donation. If they are married, they have to provide their marriage certificate. If not, they are obliged to sign a notary deed prior to their treatment. Thank you very much for your attention.
Dr. Robert, thank you very much for great presentation. So now it's time for questions and answers session. We already have a couple of questions, so let's start.
Okay.
Let's start.
How many blastocysts do you discard after PGS?
Oh, okay, sorry, because it does not appear on my screen yet. I think, can you see the question? Fantastic. How many blastocysts do you discard after PGS? Yes.
Yes. Of course, it depends. It depends. The point is, as I explained, that in the case that we have very good sperm and confirmed donor patient, the possibility to have a good blastocyst, positive PGS test, euploid embryos, it's very, very high. In this case, it may be 100%. In the case that the sperm is abnormal or it's a lower quality, the possibility to have the blastocyst non-euploidic is higher, is much higher. And in this case, I think that the PGS is the answer to our patients and transparent way to answer that if they have normal euploid blastocyst. In this case, we will have over 60% possibility to have positive test and normal implantation. And
thank you very much.
Second.
Yes. Oh, sorry. Yes. Okay. Next question. What do you use DNA fragmentation test results for? To decide to do ICSI or to tell the couple to use sperm donor instead?
Actually, the DNA fragmentation test is a way to know how many, what is the percentage of the damaged sperm in the sample. That, for example, we have 10 millions of sperm, normal physiological sperm. By DFI index, we are able to know what is the percentage of damaged sperm. That we will see that it's under 30%. It's okay for our procedures. The ICSI procedure is absolutely normal in this case. If the DFI index is over, for example, 60%, we have a big problem with the sperm. then we must inform the couple that here is a great possibility to have abnormal blastocysts, and to lead them to decide what will do. If they want to perform the IVF with the husband's sperm, with this possibility, with this dangers, or to proceed into the donor sperm. Okay.
Okay, thank you very much. Next question. Do you do an antibody screen test of the recipient to check if it is of relevance to choose by blood type or not?
Of course, it's possible, but actually we don't use it every day because the quality of IVF and the possibility to have the good results depends in general on blastocyst quality. If we have checked recipient uterus without any complications, fibromas, in many cases we perform the hysteroscopic evaluation with some scratching, that the possibility to have the negative results due to antibodies reaction is very, very low. In these cases, we use in the time of embryo transfer, we use intralipid infusion to help a little all the system.
Okay, thank you very much. Next question. Why do you match between blood type and rhesus type?
Why? Because it's due to our Greek law that obliged us in the first step to match the blood type and rhesus type between the donor patient and recipient patients. And I think that from the point of view, the normal couple, it's something value that you will never have problems with this data.
Okay, thank you. Next question. Do you have some quality system for the eggs in your clinic?
Yes, of course. In every stage, we have the assessment of eggs and assessment afterward of embryos. That, first of all, it's after the pickup of the eggs, there is the time for assessment of the eggs and to be sure that eggs are mature and are ready to vitrification. The egg, which is not mature or not normal, is not involved in the process of vitrification. That it's a very simple biological test for the eggs. Only good eggs may lead to the vitrification process and to be ready for our future movements.
Thank you very much. Next question. How long will we have to stay there after an embryo transfer?
Actually, we keep here girls for 1 hour in our unit with to rest and to hear a little light, good music. And afterward, she's ready to come home. It's not obliged, it's absolutely not obliged to stay here in Greece for a long time. It's not, there is no connection between the pregnancy rate and the resting period after the embryo transfer. If the embryo transfer is it's a very short procedure and it's no complications. The blastocyst, which is inside the endometrium, have a receptors, and she is ready to start the implantation process. That it's absolutely like in the normal body, in the normal process of fertilization, that it's absolutely nothing different. We prefer to not keeping here women for a long time. It's absolutely no connection with positive or negative test.
Great, thank you very much. Next question. Do you transfer 1 or 2 blastocysts per time? What do you recommend? What's your recommendation?
Yes, oh yes, of course. Actually, this is the point to discuss with the patient, and what do they want to do. If we have good blastocysts, it may be the single blastocyst transfer is the best way to not to risk the twins, of course. If the blastocysts are in the lower quality, or if we perform the second embryo transfer, maybe in this case we will transfer 2 blastocysts. But in every case, it's a matter of discussion here and the decision by both patient and doctor.
Okay, thank you. Another question from Anita. What are your missed abortion rates?
It's about 8% in our clinic.
Okay, okay. Do you work with vitrified eggs only?
No, no. We, as I explained in the first webinar, we have many options, and what eggs we will use depends on agreement with patient and with possibilities of the patient to be here and to be involved in the process of sperm sampling or waiting here for the donor pickup. That we prefer to have sperm here and frozen sample and to use fresh eggs to our patients. But as I explained, the point is not to concentrate that we use vitrified not. The point is to have the very good sperm and the very good synchronization in all conditions, and then the results are very similar.
Okay, thank you very much. Next question. Do you use prednisolone, aspirin, or embryo glue in your clinic? When and why?
Yes. We use these drugs and this medicine in the process of preparing to embryo transfer, we started to use the corticosteroid, aspirin, and sometimes the heparin injections, which are subcutaneous, that it's very easy for the patient from the moment of fertilization, that it's 5-6 days before the embryo transfer, and of course it's continuing for all the period after, until we have the test positive, and afterward, of course, in very personally, in every case we changed this medicines.
Thank you. Next question. How many days before transfer do you start to give the recipient progesterone?
Actually, we are starting from the first day of the period, step by step, of course, with from very low doses, growing it step by step, and then do you ask me about progesterone? Okay. No, we are starting with estrogen from the first day of period, and the progesterone we will start in the day that we start fertilizing the eggs. That if we mean that the day 0 is the day of normal ovulation of the patient, we perform this stage until 6 days. That 6 days before the transfer, we give normally progesterone. And progesterone, of course, with in many cases is, for example, vaginal cream or subcutaneous injection. It's depend on patient. It's depend on case. That we must keep it in our mind that it's 6 days before embryo transfer, in case that we are talking about blastocyst. We are transferring only blastocyst, but it's 6 days in every case. And of course, we continue this progesterone for another days until the positive pregnancy test, and until at least to hear the heart rate of the embryo. If we hear the heart rate, we will step by step decreasing the number of pills or the volume of progesterone.
Thank you. Next question. This is a question from Karen. I had a frozen embryo transfer, a 5-day PGS tested blastocyst. I had an endometrial scratch. My endometrial lining was described as perfect. What do you think went wrong?
Yes, it's a very good question, and
so I understand there was
and difficult to answer. But first of all, if we say that the blastocysts are tested and they are euploid, of course, this is the point that not every blastocyst have this implantation ability. That it may be the tested blastocyst and euploid blastocyst, but the stage of the blastocyst will be worse. This is the first. Not all blastocysts are equal. This is the first. The second is that endometrial lining was described as a perfect. What about the synchronization? About the transfer? We measure, in every case of our patients, we measure the progesterone, we measure estradiol, the level of estradiol and progesterone, and we carry and we care very, very strictly about the progesterone level. If the level of progesterone is high, we stopped the transfer and do it again from the beginning. This is very important, this synchronization. The one day that we will lose in the progesterone, that if we lose the one day with progesterone low and high, the result may be bad, maybe negative. And of course, we had cases like this, and then I'm talking from the experience, our experience. It's unfortunately it's able to see the negative results in this case. And the conclusion is synchronization of the transfer, very detailed hormonal assessment in the substitution protocols, at least 2-3 times, to see how the progesterone is rising or not. And of course, to have the good endometrium with normal and normal measurements, to be sure that the measurements are equal, and we are talking about the same doctor or the same ultrasound equipment in which we are measuring. I also met cases with endometrial scratching, which was not absolutely normal. And in this way, we prefer to do the hysteroscopic evaluation to see the endometrium and to perform it by ourselves here, to be absolutely sure that we see the conditions which are in the uterus. I think this is my answer.
Thank you very much. We have a couple more questions. Let's check the next one. Is there immune suppressant medications? If not, why not?
We are using corticosteroid, for example, Medrol, 2 tables per day, and in our opinion, is absolutely enough to have a very small suppress. We are starting this medication, as I said, 5-6 days before the embryo transfer. In very special cases, which we have confirmed immunological problems, there is an option to start these medications from the beginning of the cycle. It's absolutely nothing else. It's enough, in our opinion.
Thank you. Next question. What if the pregnancy test comes negative? Should the patient have no need to stay in Greece until a pregnancy is confirmed?
No, it's not necessary, of course. Most of our patients come to their countries the same day or the day after of the embryo transfer. It's enough, and then continue the medications and wait for the test, blood test, which will be done in their countries. It's absolutely not necessary to stay here only for this reason. If we add some kind of vacations in Greece, of course, it's another point to discuss. We are very, very attractive places here, and very touristic resorts, and many resorts, very well-known resorts, about 100 kilometers from our unit, that it's very easy to add this period of vacations to the process of therapy.
Okay, thank you. Next question. How important is in matching is the height, weight, hair, and eye color?
Of course,
How important
we
is
have
the matching process?
Yes, of course, we have this option to our patients. It depends on patient. We have some patients who inform us that it's no point to discuss. They don't interesting in this. If the patient interesting, and if it is important for our patients, we will do all the best to match the donor recipients based on this signs like height, weight, eye colors, hair colors. It's absolutely normal procedure.
Perfect, thank you. Question about PGS. Do you recommend doing PGS?
Yes, we recommend, because in our opinion, the PGS, it's a very good method to answer and to be transparent for our patients, and to absolutely say them that the blastocyst is euploid. If the blastocyst is euploid, we have a higher possibility of pregnancy rate, and of course, any negative results must be discussed more deeply, and then of course our responsibility for these results is higher than in the case that we don't know what blastocysts we have. In the case that the PGS is normal and we transfer to blastocyst, for example, to euploid blastocyst, we must have the positive pregnancy. And this is the option. If it's negative, we must try to look for something else, like some dysfunctions in the endometrium, to help it by hysteroscopic scratching. This is the point. The PGS in the IVF procedures, it's absolute future for us, and at the moment is an expensive procedure. This is the problem. Probably in the next 5 years, the PGS will be accepted. The price for the PGS will be acceptable to more patients, and it will be absolutely routine procedure in all IVF centers. It's real it's a real transparent value for the doctors and for the patients.
Thank you. We have another question about matching the donor with the recipient. How do you match the donor beside the blood type or the hair color, etc.?
Okay. Of course, first step is to collect all the recipient patient signs, and of course, by our law, is recommended to match by blood type and rhesus. This is the first step. The second step is to see what about the height, weight, education status. For example, it's also very important for the part of our patients. The color of eye. Of course, in very rare cases, we have the special recipients here who need, for example, the black color donors. It of course more difficult for us, but it's possible that we take all these points that it's are important for our recipient patients and try to match the donor with these conditions that are sent to us.
Okay, thank you. So it seems that the most important thing is matching the blood type and rhesus group because it is obligatory in Greece. Is that right?
Yes, of course.
Yes. Okay, thank you. Okay, we have another question. Do you recommend ERA map?
Of course, every test, another test is very it's very good for us, and it's have a value for us. Of course, the endometrial receptivity test from iGenomics is it's a very precise test. Of course, there is a very huge discussion about they are some progress in this case or not. It's of course not for all patients. It's absolutely not necessary to use it in the cases, very simple cases, or if the patient is going to have the first embryo transfer, for example. But if we notice that we have some problems with synchronization, that we have problems with progesterone rising, that of course is very important to find this implantation window, which is very different for every patient. That of course we recommend ERA test, but in some special cases, not by routine procedures.
Thank you. Next question from Ayala. How do you check the family medical history of the donor?
It's a matter of our of our procedures here, that the donor spent a long time here to fulfill the history. Then we check 2 times their answers, and to check it again to fulfill another medical history, sure that all this data that was collected match each other. We have very deeply family medical history based on ACRM, American Society of Reproductive Medicine guidelines.
Okay, so do you simply contact the potential donor's doctor, and do you get the medical documentation from the doctors, from other offices? Does it work like this? Or do you do the tests of the donor yourself?
No. We test and we talk with donors here in our donation office, that we have the staff which is involved in this process very detailedly. The donor visits our clinic many times to be confirmed to the next step. That in this process, all this data are checked, and again, that we have 3 levels check of the medical history and the status of a donor.
Fantastic. Yes, that's even better. Thank you very much. Okay, next question. We have a couple of more questions. Do you control the level of progesterone during stimulation?
Yes, of course. We routinely control the level of estradiol, LH, and progesterone during donor stimulation, and of course during substitution protocols in our recipient. We also routinely check estradiol, LH, and progesterone to have all the relationships between the levels of hormones. It's very important to us, and we support this exams very much.
Thank you. Who selects the donor, the clinic or the recipient?
Of course, we select the donor for the recipient, and in most of cases we prepare 2-3 cases, 2-3 profiles of donors for every recipient, and of course we allowed them to think about it and to choose the donor, of course, with our comments, with our advices. This is our routinely procedure.
Thank you. Next question: how many blastocysts do you guarantee in your egg donor program?
We from the beginning of our program, we have now some statistics, and this is the real value that I can say that 3 blastocysts is an average number, and of course more if the sperm is good. 3 blastocysts, it's a minimum to have at least 2 embryo transfer, and then have over 65% cumulative pregnancy rate in our clinic.
Thank you. Question from Ayala. How can you make sure the information the donor gives you about her condition and family medical history is correct?
Yes, this is the point, of course, of our investigation. As I said, we have 2 steps on confirmation of these details, of this data. Then in the first meeting, collect some informations and write it. Afterwards, we give them very detailed medical history to take to home and to bring in the next visit, that it will be match what they write in the what they answered in the first and what they answering in the second. And if the donor patient is confirmed to the third step, that it will be done from the beginning by another staff person here and checked for the third time. It's a very, very rare to have a donor who is such smart to give you the wrong and not realistic data 3 times in 3 time compartments to 3 another staff members here. That I think that it's absolutely confirmed. We haven't any case that we noticed that we have here wrong data.
Thank you. Question from Fiona. How thick should the endometrium be? What's your recommendation?
Of course, it depends on the age of the patient and on the normal functions of the endometrium. It's not easy. It's not easy to count and to say that this patient must have 7 or 8 or 9 millimeters thickness of endometrium. In some cases, for some patients, 7 millimeters it's enough, and this is the high level of their possibility to grow the endometrium thickness. For another patient, the thickness about 10 millimeters may be low. That very, very important thing is to check it and to have some monitor cycle, sometimes without medicines, and in some difficult cases or special cases with using some medicines to see what is the reaction of the endometrium for these medicines. It's not, of course, routine procedure, but I think that it's absolutely in our strategy of personalizing reproductive treatments, that we must see every patient from another point of view and to check all these things from the beginning. That we haven't the same patients. It's absolutely critical to estimate and to prepare the personalized procedures for every patient. The answer is that, of course, we prefer the endometrium over 7 millimeters.
Thank you very much. We have 2 more questions, and I think we'll be slowly finishing. 2 or 3. Which freezing media do you use for blastocysts? Do you do collapse by laser before freezing? And do you do assisted hatching when thawing? Question from Anita.
Yes, of course. We use routinely kitazoto freezing solution for blastocysts. And after thawing, we do assisted hatching or collapse by laser before freezing, but not both of them. One technique is enough. And of course, we have done here some research now, and we have the results that it's very, very important to leave the blastocyst after thawing for at least over 3-4 hours to see what is the condition of the blastocyst after thawing them. And then if you are waiting a little more, you can have the normal hatching without any ingression from us. And this is natural hatching. And I can say that in the half of number of blastocysts, we noticed this process. It's a natural hatching. This is the answer to the patients who are here and who are waiting for the embryo transfer. In many cases, the lab is waiting to see the natural hatching of the blastocyst. This is the reason that we prefer to wait some hours, and in many cases it's not easy synchronizable with the patient who is waiting, because we thaw the blastocyst in the morning, and then some blastocysts may be ready for 3 hours or after 4 hours, but some others need 5 or 6 hours. Then we use all these procedures, natural hatching or laser hatching, that it's depends on decision of our lab director.
Thank you very much. Two more questions, and we'll be slowly finishing. Question from Ayala. Is there a possibility to receive a blood sample of the donor in order to eliminate mutations that cause cancer?
Yes, of course. This is the new trend in the good practices, actually, to prepare the panels, the genetic panels, which have all the available mutations in the one community of donors of same nationality, for example, because it's performed for South European, for North European, East European. It's another panels that, of course, we used this panels here with example antigens, BRCA antigens for the breast cancer. This is very common now. And of course, for many others, we have the test which we call the color test, and we are talking about 30, 40 40 types of mutations which involve breast, ovary, endometrium, stomach, colon, and other organs. Yes, of course, we used it, and I think that it's a future of preparation of screening of donors, and not only the donors, normal IVF patient. And of course, it will be progressively growing, because it's a real value for all of us.
Thank you. And I think we're going to do the last question, and we will be finishing our webinar. The last question is from Anne. Is iGenomics pregenetic testing of the egg donor or the male partner required if you are doing PGS of the embryo?
Yes, this is the another things we are talking about. Absolutely, another other tests. The pre-implantation genetic screenings shows us that the embryo is euploid, that the embryo has the normal karyotype, that we haven't any problems to have afterwards some genetic diseases based on the karyotype. Pregenetic testings and this panels, which we are discussed before, are about another mutations which are, for example, in one of the partners, or in general in the generation of people who are living in the one place of world here in Europe, that it may be monogenetic diseases, and then we must say here that actually we try to examine all, but it's impossible at the moment. At the moment, we have many monogenetic mutations, which are very, very difficult to us to examine and to exclude the patient, the donor patient, from the pool. That every test which we perform now, every day is better and better, but still we have many monogenetic diseases that we can't examine them before the procedures. I think that in the next few years it will be of course researched, and it will be improved, but at the moment we must say that we do all the best. We examine the patients based on the level of patients, the donor or the recipient, and afterward we examine the embryos, the blastocyst, but it's still not enough to have all the genome information about them. That it's still improving, but it's not the end.
Thank you very much. Okay, that was the last question. If anybody has any more questions to Dr. Robert Najdecki from Assisting Nature, you can email me the questions at dorothy@ivfmedia.org, or you can contact the clinic directly from our website. Dear attendees, thank you very much for being with us. I apologize for the sound issues some of you had. It is very weird because from my end, the sound was pretty clear. However, we will do our best so that the troubles don't occur next time during our next webinar. And of course, you can see the recording of this event tomorrow on our website and on our YouTube channel. Dr. Robert, thank you very much for the presentation and for answering so many questions. It was lovely to have you, and I think your answers turned out to be very, very useful to the participants. Thank you very much.
Thank you. Thank you very much, Dorothy. Thanks to all. It was a great pleasure and great opportunity to exchange some ideas and some topics and issues about IVF and about egg donation. Thank you.
Yes, we had really lovely questions. Every fertility case is different, so we are learning something new every day. Okay, dear all, thank you very much. Have a good evening, and hopefully we will meet during our next webinar in two weeks' time. I can see somebody is asking about our website. Anita. Okay, Anita is asking about our website. Let me pull out the link for you. Our website is eggdonationfriends.com. This is the link. After the webinar finishes, you will also be directed to our website, so it will open automatically. You can visit the page and you can read more about IVF and donor eggs. We have articles, webinars, and other useful materials for you. Okay, fantastic. Okay, dear all, thank you very much, and have a good night. Good night, Dr. Robert.
Bye-bye. Good night. Good night.